Good evening, everyone, and thank you for joining our final Compassion Chat of 2022, the November session. We will not have a session in December because we want to be with families, celebrating holidays and doing all the crazy holiday stuff that we do. So thank you again for joining us. We have been doing this since March of 2021. We record every single one of these sessions. So if you would like to just go and browse to see what's there, please, by all means, check in. SusanAMarshall.com is where you find the archives. Also, if there is a particular topic you would like us to discuss in 2023, shoot me a note, Susan@SusanAMarshall.com. Again, Susan@SusanAMarshall.com. Just let us know what you'd like to hear us chat about, because this is a chat format. We have the coolest people on the planet. And this month is absolutely no different, though the topic is one that everybody's like, ugh, billing. No, don't make me go there. Nicole Broadhurst joins us this evening. She is a maven of billing. She's extraordinary. And Nicole, I'm just so eager to have you chat with us this evening. Thank you for joining us. Tell us where you're joining us from.
So I am actually in Tennessee, just between Nashville and Knoxville, north of I-40, between the two. So I'm equal distance from Nashville and Knoxville. So
that is super cool. And joining us in the tundra of Wisconsin, actually today was downright balmy. We got up to 40 degrees, but we had really wicked cold weather and snow already. So
oh goodness.
We love to start these chats, Nicole, just to getting a sense of who you are as a person and what in the world took you to, your bio briefly says, from healthcare administrator to independent billing advocate. So that's kind of the end point, but give us a little story. What's your background?
Oh, yeah.
What moved you to do the work that you do?
So I started out as a certified nursing assistant in a skilled nursing facility a long time ago. Let's see, when would that have been? That would have been like 1990. So I worked second shift, and I was kind of anyway, I started there and I loved where I worked. I loved the facility I was at. I loved the residents and the families and the nurses and everybody that I worked with. Probably 6 months into my rotation as an aide on the floor, I had a really traumatic experience. I went to turn a resident, and she was bedbound, and I used the sheet, and pardon me, and the sheet caught on her arm and caused a horrible skin tear. And yeah, that was the moment. It was horrible. It was life-changing, quite frankly. I
just have to tell you, Nicole, I've got full body chills right now, just even imagining what that
was horrible. So I reported to my nurse. I did the things that that you have to do. I reported the incident, and then I proceeded to the director of nursing's office in full-blown tears, and just said, I can't do this. I can't do this work. I'm not cut out for this. And she said to me, well, my administrative assistant just quit. Do you want that job?
Okay. Well, wait. I just had this traumatic experience. Administrative assistant. Did you say talk to me?
You know what? I loved where I worked. I loved who I worked with. And I didn't. I said yes. Like, I immediately said yes. There was no hesitation. There was nothing. It was because it wasn't about where I was working or who I was working with or what I was doing. It was the physical part of the work that it wasn't for me. So two things happened in that moment. One, the trajectory of my career changed. And two, I realized the true depth of compassion and the type of person it takes to give direct patient care. And both of those things led me into administration and healthcare to serve in a way that was in alignment with me and also in alignment with the gifts that I have, which are not in direct patient care, but in administrative, financial type of support. So, and then there was a long thing in between there, right? Like I did that work, and then I did purchasing. I worked in supply chain management, and then eventually I moved into administration. I went back to college, got my degree, and moved into practice administration, marketing. I worked across the continuum. So I moved from skilled nursing facilities through hospice and home care. I worked in the hospital. I did outpatient specialty clinics, primary care clinics for a while. So just a general overview of the whole system eventually. But it all started on the floor in a nursing facility.
And it's interesting, Nicole, probably the most stressful and least understood aspect of caregiving is the work that you now do. You know, it's interesting. Part of your description said, take control of medical bills in 30 minutes without making a single phone call. Talk to us. That is amazing.
Yes. So here's the thing that I think is most interesting about the billing aspect. I have a moral issue with the billing aspect and the financial revenue cycle of healthcare. I feel that it's just plain wrong for us to layer on a financial burden, concern, worry, stress, frustration, in addition to all of the other things that are happening in the healthcare system, right? You're sick, you don't feel well, you've had surgery, you're trying to recover, whatever, like the list goes on. And then to add salt to the wound, there's this lingering, is there going to be a bill? And how much will that bill be? And all of those questions. My goal is to just take that away. Like I want that alleviated from all patients and all families. And what I learned is that it's easier for me to help in that way than it is to change the system, which is what I tried to do for a long time. The system is what it is, and it's very frustrating. But so you can make a phone call, like you can call me, and then all of the things we'll get them resolved. We'll get them resolved. I just shared with you earlier before we started that I had a friend who was literally on his way to the emergency room with his son who was turning jaundice. He calls me and he says, Nicole, we don't have insurance and I don't know what this is going to be. Now, mind you, his son is in a medical crisis, like an emergency, right? And here he is calling me about the bills and they haven't even happened yet, right? That's how pressing this is on us as patients and families. This is what I said. I said to him, I'm not afraid of those bills. You can get the care that your son needs. We will manage the bills later. And I think if I could say one thing to people, that's what I want to say is don't be afraid. Like there is nothing that is going to happen that you can't deal with. And that's
encouraging to hear because most of us have been led to understand and fervently believe that we can't dare get so sick or we're going bankrupt. We will lose everything we've worked our entire lives for in order to survive whatever the illness is. So talk to us about you're saying things that most people be like, what?
Yeah.
Come on. How can that be true?
Yeah. So I think the biggest thing to remember is to deal with it, right? Like we hear this when we're little all the time, right? Don't ignore things. They don't go away, right?
That was one of my questions to you was going, well, two, what are the most common mistakes? And then two, talk to us about the pain and procrastination.
Yes. So it gets worse. And I tell people this all the time, if I had I think I've said that already, one thing, right? But if I had one other thing, it would be don't ignore them, right? Do something immediately, even if you don't know what to do. right? If you don't know what to do, then make a phone call, go to a directory, find somebody like me that can help you make the right choices on handling it before it becomes an issue. The hardest cases for me to work, they're not impossible, but they are harder, are the ones where I've ignored it. And now they're all in collections and they're all like, it's, and again, not impossible. In fact, it's really, there's a lot of techniques that we can use to back those out of collections, but it just gets harder, right? Things get messier.
So Nicole, you are in Tennessee.
Mm-hmm.
I'm talking to you now from Wisconsin. People are all over the country. How in the world do you find someone like you? What are the criteria we should look for? What background? Is there credentialing involved? So help us understand how to even start looking for someone like you.
Sure. Yeah. So I am a board certified patient advocate. And I know that you've talked about this briefly in the past. So any of the directories, you've got advoconnection.com. You've got GNA Now, which is Greater National Advocates Now.org, are two big ones. Then there's NAHAC, NAHAC.com. And there's directories of board certified independent patient advocates, and there's different specialties. And so you can look for medical billing and insurance. And generally, most of us in this area have inside experience like myself. Either we've worked for hospitals and health systems in the past, or we've worked in the insurance industry and are very familiar with the adjudication process or the claims processing side of things, so that we have that type of experience to bring to the table.
So with your background, the ins and outs of the billing system. Is that through the evolution of your experience and the transfer from the direct patient care to the administrative side of things?
It is. It's a direct relation to having worked in that cycle for many years, right? Part of my responsibilities as an administrator are the revenue cycle, the profit and loss, watching how the money comes in, where it comes in from, right? All of those things. And yes, so for me, what ended up happening was families for years have brought their mail into my office and said, this looks like a bill, but it says it's not a bill. What does that mean? Right? All of those things. And honestly, I've always enjoyed that, like sitting with them, explaining it to them, because it looks very foreign. It's not like a receipt from the grocery store, even though it should be, but it's not. And so I took all of that and then, went to actually help the patients and families in a way that was really going to be beneficial. So
those statements that we all get that says, this is not a bill, and Medicare does that, right? If you visit your pharmacy, for heaven's sakes, statement of benefits, right?
Yes. Right.
Versus an invoice or an actual medical bill.
Correct.
What are the key components that are generally included on that statement of benefits that we can train ourselves to look for?
Ooh, love it. Love that. So there's going to be, the biggest part is going to be the you may owe box. Okay. That's the key box. So if you get a statement of benefits and you get a bill. So first of all, never pay a bill without getting the statement of benefits. Okay. Just call them and let them know, hey, I'm waiting for this to process through my insurance, and then I'll be happy to pay. And then when you have both of those documents, make sure that the bill amount matches the amount in the box on the benefit statement that says you may owe. Those two numbers should always match. If they don't match, there's a problem.
And sometimes they don't match.
That's right.
And so that's then another place where people tend to put it on a stack. I'll deal with it. I don't know what to do. I'm going to just leave it there. And maybe somebody will figure that out. And maybe in a month or 2 months or 6 months, I'll get another invoice that will match that box. What do we do in the meantime?
Yeah. In the meantime, I would call the bill, whoever sent the actual bill, and just ask them. Just ask, because a lot of times they may know and they may say, okay, so rewind. One of the things that I bring in my experience is I've been doing billing and in that situation for a long time. So long that I'm going to tell you, when I did billing, I sat at a typewriter and I typed claims. And then I put them in an envelope and I mailed the claims once a month.
That's a long time ago, Nicole. I can totally relate to this.
Yes. So I actually did a beta in Metro Detroit where we transitioned. I worked for a big health system and we transitioned from paper claims into electronic claims. So I was part of that process. And what I can tell you is that, yes, technology is wonderful and electronic claims are wonderful. It definitely speeds up the process of, exchanging money and getting paid. However, there's a lot of automation that has happened and there's been a lot of removal of human interaction. And so back in the day, if a claim got denied, I had a claim representative at the insurance company that I could call and say, I had 12 claims that were denied on this day, a whole batch. What is going on? And they could look into it and they could help me. Now that things are automated with electronic claims processing, that doesn't happen. And so when claims get denied or they get boggled around or botched up, there's not necessarily a person that is there touching it.
Amen. That's the problem we all struggle with in this healthcare system today.
Yes, very much so. So back to the original question, the boxes don't match. What do I do? Right? I call the doctor's office. I call the billing department. I say, this is really strange. I've got my EOB and the numbers don't match. Can you help me understand? And what this does is it brings it to the attention of a person, right? Because everything's just processing along, automatically, and it's going through the system. But when you make that phone call and bring someone's attention to it, now we have a person involved that can look at it and go, yeah, you're right. That's weird. Probably need to look at that. So again, don't ignore it. Just be curious, right? I have to say that 9 times out of 10, it really is just an error. It's not some devious thing that's happening. It's just an oversight, a processing error, something that just has been missed.
So one of the things that I think we also, when we get into the system for whatever reason, big reason, little reason, doesn't matter, we find that people who look at these things and work in doctors' offices and clinics and all are fairly transient these days. They don't typically know a lot about even the words you said. What's your advice when you're on the phone with somebody and you can tell they're giving you the yeah, and they're not going to do anything? What next?
Thank them for their time. Thank them for their time. Let them know that you appreciate them doing what they've done. And then the next thing is twofold. If you're calling, a lot of times you're calling a call center, right? It just is what it is, right? We're calling a call center. And so there's a couple of things we can do. We can hang up, be very polite, hang up and call again and see if we get somebody different. I mean, I want to say that there's some crazy trick, but the truth is there's not. It's really that simple. If we do that, this happens to me all the time. I make a phone call and I can see that I'm getting the runaround and I'm just like, you know what, Susie, thank you so much. I really appreciate your time today. I'll keep working on this and get off the phone. And then half hour later, the next day, I call again and I get John, and John happens to be super helpful. Like John is Johnny on the spot. And he's, you know what, you're right. We need to reprocess this. I'm going to send it through. So there's that. And then in the event that you can't break through, like there's just like I called 2, 3, 4 times and I'm just not getting anywhere. Don't be afraid to start looking for the key people in administration. I wouldn't suggest jumping right to the CFO, but don't be afraid to go there if you need to. I've been known to call CFOs and literally leave messages saying, I really hate to bother you with this. I understand that this is not your day-to-day workflow, but I'm running into a problem here and I just need some help. Most of the time, I don't get a call back from the CFO. I get a call back from the revenue cycle manager, someone that can actually help me. So don't be afraid to keep looking and asking for elevation. One of the things that I know, and it gets challenging, because everybody's really trying to do their job. Right. I mean, showing up with a good intention to do the right thing and to be proficient in their job. What you said is very accurate, is that there are not people in these roles who have the same type of experience. And so they really aren't even able to help. They may be trying, but they're not able.
And so now I'm a caregiver, right? I don't understand the statements that are in front of me. I'm scared because I don't want to not pay something that's going to create hardship for my loved one or myself, if it's my own explanation of benefits. I don't know what to do. I'm stressed. Mm-hmm. I can try to be nice.
No, it's so hard.
No,
it's so hard.
I've got somebody who I can tell just really doesn't give a flip. Not that they don't care about humans, but that they don't know how to do this thing.
Right.
I don't know, as a caregiver who doesn't understand systems, who to call next.
Yeah. So I think maybe it would be time to ask for some help and get some guidance, maybe go to one of those directories. I do a lot. Listen, the truth is that I get many, many more calls than I actually have clients. And it's because there's tons of times that in a 5-minute phone call, I can help you. Like you don't need to pay me. It's really just me sharing some information and kind of giving you some guidance. And what I can tell you about the community of independent advocates is that we're all doing that.
That's awesome.
So the message on that is, don't think that you have to pay for our services to call us. That's not the way it works. Call us for help. And if you need to engage services, then we can talk about that. But it's more important to get the help.
I'm just getting chills. That message has been so consistent since March of 2021. Everybody that we've had on said, you know what? Call. We will help you take the next step, decide what you need to do, lay out a plan. You don't have to pay to pick up the phone.
That's right.
I never knew that. I thought every phone call I made was going to be somehow attached to a bill, kind of like an attorney. And that's just not the case.
No, because there's a lot of things that it doesn't need to be a big ordeal, right? It's literally just, one woman called me the other day, and I work in front of my computer, and while I'm on the phone with her, I looked something up and I was like, hey, here's the number. Now, she could have looked the number up, but it wasn't about that, right? It was about alleviating that immediate stress and just saying, here's the phone number. I want you to call this number and I want you to ask them these questions. And if you don't get what you need, call me back.
And this is the number and here's what you say.
Yes.
Because I can call a number and then I'm like, I don't. Right?
Right. No, list of questions. Yes.
Yeah. What are some of the most common mistakes, Nicole, that we caregivers make when it comes to the whole billing process?
Yeah. I think the biggest thing that I see is not understanding our benefits and understanding what is covered and isn't covered. And it feels like a punch in the gut when we get to the point where we think something should be covered and then we find out it's not. So I always say, and I know this is super boring, right? But if there's one place that I'm going to tell you to go in your policy, it's It's the exclusion section. So most of these documents now come in a PDF form, so you can have them on your computer. Control F gives us a little box where we can find things. So if you have a PDF, I want you to do Control F as in Frank or find. And in that box, I want you to type in exclusion. Okay. And it's going to find the word exclusion in that entire document. And then you skip through and you read every single sentence of what it says it excludes. And those will be the things that absolutely are not covered under your policy. Okay.
So stay with that thought, because I've already had a procedure. I have this bill, which is why I'm freaking out. Now I go to my PDF, I Control F, and it's right there in the exclusion. Now what do I do?
You call an advocate to help you navigate that, because now we're in a situation where technically and legally, right, there is a bill for a service that was rendered that there's not any coverage for. Now, that doesn't mean that we can't work through that bill, but that's a whole process that that would be bigger than most of us could do on our own.
And that would be the kind of service that I would happily pay for, right?
Yeah,
because
right.
I've got this big bill and I'm panicked and I have no idea what I'm going to do.
Yes.
I'm bankrupt, right?
Yeah, exactly. Now, just to put some real scenario around what you just said, I literally just finished a case where a gentleman had an ankle replacement and he thought that his insurance was going to cover it. They did a benefits verification. They called him the day before surgery. They said, this is going to be your responsibility, X number of dollars. He paid the X number of dollars. And then after everything was said and done, he got a bill for $169,000.
I can't even imagine.
It was, yeah. And it was because it wasn't an exclusion, it was a limitation. That's the other word that you can put in there. It was a limitation. His outpatient benefits were limited to $2,000.
Oh.
And that's all that it paid. Now, I worked on that case for months and I was able to get it negotiated down, and he was able to it was still a significant payment. I don't want to make it sound, it was still a significant payment, but it was significantly less. In fact, I think the total due when we finished up was like 22,000. So, again, huge numbers, right? And so, but there's other things that can be done. That's just one scenario. And fortunately, he was able to go ahead and make that payment and take care of that. If you're not, then there's interest-free payment plans that we can work on. There are financial assistance, which is one of the other things that's a whole nother show, probably want to talk about financial assistance. But don't discount that, because lots of us will qualify for financial assistance, even when we don't think we will. So
that's a really important point. I think most caregivers in the circles that I've been in now for the last number of years have no idea there's additional help, and feel like because we have these commercials, if you've been injured in this, you may be. It feels like such a hustle. Mm-hmm. That most people will go, you know what? I'm not even going to bother with it. I don't know what I'm going to do, but I'm not even going to ask.
Right.
And what I'm hearing you say is ask.
Absolutely ask. In fact, another little tip on the phone, when you get into a spot where they're like, okay, we're butting heads and we're not getting anywhere, I love to ask the question, okay, I understand. I can't pay the bill. It's not going to happen. Like, I don't have the money. It's not going to happen. Now, what do we do? And just ask, now, what do we do? Because if you've got somebody on the other end of the line that is, has some compassion and right, they're going to start thinking, okay, well, what do I tell this person to do? Like, how do I get them help? What are the options? And so just asking the question is is the beginning.
Well, and I think that's so, so important. Again, in the context of compassion, I might not ask for myself because I don't know how, but I certainly can ask for a loved one because I have assumed this responsibility of taking care of them. Right. And it's a mental shift, but I think for some people I'm not asking for me, right? I'm asking for a friend. I'm asking for somebody that I love. So
it's really interesting. Oh, go ahead. I'm sorry.
I was just going to say that's such an important thing, is just to remember you are a human being in need, in distress. Don't hide that.
That's
I mean, you don't have to get all drama queen crazy about it, but say you need help.
Right. Absolutely. I had a thought as we were just talking about this, Susan, and thinking about, one of the things about why a lot of times I will do something and a client will say, well, I called and that's not how that went, right? What did you do that was so different? And I was just thinking as we were talking, you know what it is? It's not me. It's not me. It's not my bill. It's not my health, right? So what I was just thinking was, for caregivers, what if we had a caregiver buddy and I called on your bills and you called on mine?
That's a cool idea.
I
love that. Add that
right?
Services, would you?
Right. I mean, I think that would, because that immediately takes some of the emotion out of it, right? Because I could call on your bills all day long and not get super stressed, right? I mean,
right.
But so that's an interesting, that might be, if anybody out there decides to do that, let me know. I want to hear how that goes.
I think you should just do it, Nicole. Come on, it's a natural. But I think you're right. And I think you've hit at something that has really been kind of a consistent theme in these chats, is that sense of almost shame, the guilt, the inadequacy, all of those things that caregivers so often feel. I certainly did. When I was watching my parents decline cognitively, you can control none of that.
Right.
And so it's hard to talk about, and it's hard to take the kinds of steps you're suggesting. I could do it for somebody else.
Yeah.
That's a brilliant idea.
Yeah. I do. Maybe we should make a club of some sort.
We got a group here who would certainly love to explore that idea with you. So
I would love
that.
Yeah.
Yeah. So in regards to that, one of the questions that I had for you is, much like you said, this gentleman had this huge bill. How do you challenge a charge, whether you think it's right or wrong? But so it's kind of a mindset thing. But then what, much as you said, what words would you use? Yeah. How would you frame that challenge?
Yeah. So I love that question, because I want to go into all of this, like how they come up with their pricing and how, but here's the bottom line. The bottom line is that the charge itself is a made up number. Okay. So it literally is a made up number and it's not real. All providers negotiate their reimbursement. Okay. So they don't negotiate. Here's the thing. They don't negotiate their price. Okay. Their price is their price. They set their price, but they will negotiate how much they accept for that service, their reimbursement. Okay. And I know that sounds like I'm picking at words, but here's why that's important to know. I think that medical bills right now are at a huge buzzword. Everybody's talking about them. And I'm just going to be totally honest with you. The hospitals, the health systems, the billing people, they are feeling the pressure. Okay. They're feeling it. And their immediate guard is to defend where they stand in everything. Okay. So it's really important for us to understand that when we do go in and we want to talk about these things, we want to use really neutral language, right? We want to use language that doesn't poke and prod the bear. Right. And yes. And keeps us on the same side. Right. the side of we want them to get paid for the services that they provide. I have yet to meet a patient who just doesn't want a doctor to get paid. That's not true, right? We want them to get paid. We want them to get paid for the services that they provide, but we want it to be fair, and we want it to be equitable, and we want it to be within reason. And we don't want to feel gouged and taken advantage of.
All of
right?
those words are true. And as a patient, I have no idea what's fair.
That's right.
I have no idea what's equitable, and I have no idea what's reasonable.
Yeah.
So I'm automatically feeling like, so here's the authority figure and here's poor little me. I don't have any way to bridge gap. But I love what you said in terms of what I heard and what my brain went is we are partners in resolving this.
Yes, absolutely. Absolutely, we're partners in resolving it. There's a problem and we can take care of it. We can get it resolved. I felt another question come in there, Susan. No? Okay. Yeah, we can get it taken care of. So there's words that we want to say, things like, okay. Now there's all kinds of tools out there too right now, and they're slow in coming, but the whole price transparency thing, we are moving in the right direction. We are far from where we need to be, but we are moving in the right direction. And I'm going to tell you, there is Turquoise Health. There is Healthcare Blue Book. There is Sage Transparency. All of these are tools. They're a little bit advanced. So I would suggest if you want to use them to get fair and equitable pricing and figure it out, I would call for some help. Again, maybe we need to do some training on that. Anyway, how to use those tools. There's actually Sage is one of my favorites because it gives us a window of what hospitals are charging versus where their break-even point is on their P&L.
I'm amazed that information is even available to the public. Does that vary by region?
By hospital. You can get it by hospital system. So I can go in and pull up all of the hospital systems in Wisconsin. I can drill it down into Madison. I can look right at a particular hospital. And based on the data reporting that they have reported, we can tell exactly where their window of profit is. So again, those are pretty advanced tools, but they're out there. And those of us that are, doing this every day can help. We know how to do it. Like when I sent the settlement letter to the hospital in Arizona, that's what I used. That's how I figured out what I could offer them that would be fair. Like, I want you to get paid, right?
Right. So you just convinced me that I'm not going to go look at Sage. I'm not going to go look at those other things because, first of all, I hate technology. I'm ready to chuck my computer every day, 15 times a day. I wouldn't know necessarily, Nicole, what I was looking at.
Right.
But I know you.
Yes. And
I would call and I would say, do your magic. and then let's talk again about what would be a fair and equitable.
Absolutely.
So that would give me then a basis to call a provider and challenge a particular charge. You're right. There was an additional question that was in my mind. Very good on you. What about the codes?
Okay. Yeah. So the codes are great. But when we ask for them, we've got to be specific that we want them. There's one thing that I want to make sure that everybody knows. CPT codes, which are that's the big thing that everybody talks about. Get the CPT codes. You need to know those are only for outpatient procedures. Okay. If you are inpatient in a hospital, there will not be a CPT code for that. Okay. And that's important to know because if you ask for it, you're not going to get it. And then you're going to get frustrated and not know why you don't get it. And the truth is that there isn't one if you're inpatient in the hospital.
Well, and so talk a little bit about that because I know there's confusion about what is inpatient, what is outpatient. Yeah. Can you request one or the other? And then that's got insurance implications, right?
Oh, all kinds of things here, Susan, right? So inpatient, outpatient. So a lot of times, okay, let's break it down and be super simple here. Inpatient, there is criteria. There's clinical criteria that generally providers utilize Medicare as their main guidance on that. So if you meet inpatient criteria under Medicare guidance, then they'll probably go ahead and admit you. If you don't, or if you're close and there's questions, they may put you in what they call an observation status, which again, a whole nother show, a whole nother conversation. But that observation status really doesn't affect your care one way or the other. It literally is a status on a piece of paper. And there's implications to that. So that having been said, that's a decision that's made at the utilization review. I feel like I'm getting way jargon here. Sorry. There's a committee in the hospital that is charged with monitoring admissions and making sure that clinically they're checking the boxes to meet the criteria. And that's what utilization review means. They're just doing that. So if you meet that, they're going to do an admission. In admissions, you have different coding. You have HCPCS codes, you have DRGs. There's a whole nother.
Well, and from looking at my explanation of benefits and all this kind of stuff, nobody cares about that until you get the information that either that code doesn't cover, or somebody says, "Oh, it looks like the wrong code." How would I know that?
You wouldn't know that. But here's what I do want you to know about that, especially for you caregivers that are taking care of Medicare beneficiaries. There is what is called, I'm giving you key words here. There is something that's called a common working file. Okay, it's a common working file. And it is literally Medicare providers can send out what they anticipate billing to the common working file, and the common working file will spit back to them whether or not they're going to get paid for it. Now, hear what I said.
Give us an example.
Okay, so my doctor orders an MRI. I don't know. I'm not clinical, so I don't even know what that would necessarily be for. But the doctor says, you need an MRI. I'm going to have the imaging clinic call you and schedule it, right? So the imaging center calls me, schedules my MRI. I have to go in and I have my MRI. Now, what you don't see happening is when the doctor sends the order to the imaging center has the diagnoses, the codes, the CPT codes for the MRI, all of the things that they need, right? And they can enter it into the computer like a dummy bill, send it out. And when they hit enter, it goes to the common working file that then processes that information against Medicare's criteria. And it shoots back and says, good to go. We will pay for this MRI. We have the codes. Everything looks good. You'll get paid for it. Or it will kick back and say, nope, we're not going to pay for that. The diagnosis is wrong. Or it doesn't support, this diagnosis doesn't support this process, this MRI, right?
I think that's really important because we all know that one of the revenue generators for clinics and hospitals is testing.
Yes.
And so run the tests. And as patients or even caregivers for patients, we don't know if it's a legit test or not.
That's right. I'm actually working one right now it was a CAT scan. And, my whole premise on this is that my client should not have been billed because they should have known, right? They should have, when they sent that out and I got that back. And if they do that, here's the thing. This is why I want you to know about the common working file. If they send it out and it comes back and it's not going to be covered, this is the opportunity for the imaging center to call the doctor and say, hey, you know what? This isn't going to be covered. Are you sure this is the diagnosis that you want to use? Okay.
And how often does that happen realistically?
It used to happen a lot.
Used to.
I don't think it happens like it used to. So, but here's the thing. If they do that and it's not going to be covered, they're required to give you what they call an advanced beneficiary notice. Okay, an advanced beneficiary notice. And this is a statement that says, Medicare's not going to cover this, and we expect that it's going to be your responsibility to pay, and this is how much it's going to be.
And then do we get the opportunity to say, thank you, no?
Yes.
Okay.
Yes. And if that happens to you, know what I just said is probably true. The imaging center did not call the doctor and talk to the doctor, right? To find out, like, why are you running this? Because most times, again, we go back to everybody's trying to do the right thing, right? So most times a physician will say, well, no, I didn't order the MRI for the arthritis. I ordered the MRI for, whatever it is. How did that happen? Right? So if you get an advanced beneficiary notice where they're telling you that Medicare's not going to pay for something, say thanks, but no thanks. Obviously not an emergency situation, right? I mean, we're talking, so you say thanks, but no thanks. And then you call your doctor and you say, hey, I went to go get my MRI and they said Medicare's not going to pay for it. What's that about? And the doctor's going to go, I don't know, but I'm going to have Susie, my nurse, figure it out. Right. So, yeah.
And what I'm hearing, Nicole, is advocate for yourself, advocate for your loved one. If you don't know, ask.
Absolutely.
And I do believe that we are so intimidated by the whole system, by the authorities, by the people who literally hold our loved ones' health in the palms of their hands. We don't want to make them bad.
Right.
But we don't necessarily know how to balance that power.
Yeah.
And what I'm hearing you simply say is just ask.
Yeah. I think somebody taught me a long time ago, curiosity over judgment. And it has worked so well in my life to just be curious, to just be curious and not have, and try to let go of the things that I think are happening. Right. And just be curious about what's really happening. And I think,
Yeah, it's so very, very true. I could talk to you for 14 hours and we could do literally a month series on this, but I want to make sure we talk just briefly about it's open enrollment season, right?
It is.
So Medicare people and caregivers, and I remember going through this with Mom. I don't know one plan from the next.
I know, right?
And so what are the key things to look for based on what we know about the individual we're caring for?
Yes. So first and foremost is find a broker, an independent Medicare broker in your area that's familiar with your local policies and things available to you. Okay. First and foremost, and find one who will tell you up front that they don't do this for the money. I had one of my very dear friends is an independent broker. And she just said to me the other day, she said, I don't work for a dime. I work for a difference.
Oh, I love that. So
isn't that beautiful?
Broker?
Sorry.
What is an independent broker? Where would we find them?
Yeah.
What do they do?
Yeah. So again, I'm going to say find an advocate to find a quality broker. And here's why I'm going to say that. As advocates, as independent advocates, I've already established that we are genuinely here to help and make a difference. And so we are constantly looking for these independent brokers who are in it for the right reasons. And it is a network. I promise you, when you tap the network of independent advocates, your world will open up. So because I don't know the directories for those people, I'm going to say find an advocate and just say, I need some help with my insurance plan. Do you know somebody can help me? And I promise you they will. They will get you in somebody that will be in it for the right reasons and happy to help. And the reason that I say that is that there's a financial incentive for all of these Medicare Advantage plans. And the big guys, the big rollers, the Aetnas, the Cignas, all of them, they pay huge commissions in open enrollment for agents that are selling the Medicare Advantage plans. Now, that is independent of the policy. A lot of most Medicare Advantage plans work for people. The thing is you've got to understand them, right? And if you've got a new agent, a young agent that's just looking at the financial incentives, you may or may not get the plan that's going to be best for you. So I want to make sure that you're in it with a broker, an agent that is absolutely independent and only cares about getting you the right coverage for you and your family.
So let me ask you this. All of the advertisements we see on TV now, don't call those 800 numbers.
No, please don't. Please don't. I have to say, every year at this time, my parents are both Medicare beneficiaries. And every year I call my mother and I stop at my mom's house and I ask for all of the postcards and all of the mail and all of the things, because it is human nature. We want to make sure that we have what the best deal, right? And that we're getting the best bang for our buck. And so with all of that advertising, it's just human nature to want to sift through it and make sure. The message here is that those postcards do not give you enough information to know. Okay. They just don't. They have the highlights. They have the selling points and all of those good things, but there's no way that postcard can know how you use the healthcare system and what your needs are as an individual. That can only happen with a one-on-one conversation with an independent broker, an independent advocate.
I think that too is one of the most important truths for anyone approaching caregiving for anybody else to know. It isn't one size fits all. Never has been, never will be. And so to be clear as you possibly can be about the level of care, the history of care, and where this individual is that you are side by side with, is absolutely essential to making any of this work, right?
Absolutely. 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 You're right. There is just no one size fits all. There's too many moving parts, right? There's too much.
Well, and that's why I'm so grateful there are people like you who do know the ins and outs of all of this, who know all of those details. I'm so glad this is recorded because I'm going to go online and say, peeps, just listen to this, take notes. But that said, I think it would really be neat if in 2023, we could perhaps set up a case study and maybe put something together that is common for so many people in certain age groups and say, let's walk through this. Wouldn't that be neat?
Yeah, that would be great.
And
I would.
So
helpful. Yeah. I hope this has been helpful. I feel like I put a lot out there. So yeah. So lots of good stuff in there. Yeah. Thank you so much.
Final recommendation for caregivers before we close.
Yeah, be nice to yourselves. You don't know what you don't know. And that's okay. Right. And I think part of the process is getting okay with that. Right. We feel a lot of pressure that we're supposed to know and we're supposed to have the answers. And especially as we care for people who've cared for us in the past, right? Our parents, our aunts and uncles and that type of thing. We want to give them as much and as more as they gave to us, right? And there's a lot of pressure there. And it's okay to not know and to ask.
I think that bottom line is really it. It's okay to not know. How could you? How can you? But if you don't ask, you not only will never know, you will not have access to someone like you who can calm us down and say, we got this.
All right. It's okay. Yeah. Yeah.
God bless you for the work you do. This has been
No,
just,
you.
well, it's been a delight. And I really do want, I'll get back to you because I think in
Please.
the new year, I think walking through a case study would just be
I would love
enormously helpful to
I would
people
love it.
who are stuck, right? And then the procrastination sets in, and then the frustration, we get somebody on the call and
I know, right?
just makes it worse.
No, it does. And it quickly can spiral. I want to just, with that note, I do want to tell you, there is a hospital in Florida that refuses to talk to me anymore. So even I have been known to lose my cool. I want to put it out there. Like, it happens. It happens.
Thank you for reinforcing the humanity of all of us.
Yes.
Nicole, thank you. This has been absolutely a delight. I want to remind everyone this is being recorded. You can go back and listen to Nicole as well as all of the sessions we've done at susanamarshall.com. Click on Compassion Chats at the top of the website. You'll get the archive. Nicole, we have preserved you forever. And I will look forward to chatting you again. We'll bring you back in 2023. We have work to do.
Yeah, I think so. Thank you so much, Susan.
Thank you, Nicole. And thank you, everyone who joined us. And we'll see this. Wish you the very, very best of the close of 2022. Happy holidays. Enjoy the ones you love. And as Nicole said, be nice to yourself. Nicole, thank you. Bye, everybody.